and FRQS co-chair in AI and digital health for health behavioral change. So I think this is going to be a really exciting talk, definitely pertinent to what I'm trying to do. So I will thank you.
Wonderful. Thank you very much. Okay. Hopefully everyone can hear me okay, and should be able to pick me up. If there's any problems, just pop in the chat. So thank you very much for the invitation. It's great to be here. And thank you to ACT, who I am connected with, as you will see in a second. Before I start, I just want to acknowledge the fact that we're on unceded indigenous lands. Part of what I do is lead CBITN, which is Canadian Behavioral Intervention Trials Network, which is one of the funded CTTPs. Hence why I'm connected to ACT. And obviously, that's a national organization. So, you know, for each one of us as part of that organization, we're on very different unceded territories. So and people online might be across the spectrum. So I want you to think about where you are situated. Right here, right now, I'm situated in the Ganigahagi Nation in Chichogi. And I think what I really want to highlight is that the systems of oppression that have been built up over time still exert a huge influence on what happens with indigenous peoples. I'm very proud to say that CBITN is working very, very hard to try and address those issues. Though as much as we do, we're still not doing enough. And I think that there is a huge emphasis on us to work harder and do more. We really need to elevate the voices of indigenous people. These are my disclosures, none of which are related to this talk at all. And just to say, as I mentioned, what I'm going to do is give you a very brief snapshot of sort of some of the things that we need to consider and think about as we start developing and testing behavior change interventions. But CBITN is a great resource. There's a whole bunch of educational tools that are now starting to be developed that are available online. For those that are interested in doing work in this area, we do have a funding competition for mentees that this year's finished, but next year we'll be running another competition. So there's the information. Go to the website, sign up, get the newsletter, et cetera, et cetera. Okay, so by the end of this session, hopefully I will have been able to detail some of the major limitations in some of the behavioral intervention trials that have been published out there, and use that as a precursor to sort of talk about what can we do a little bit better than we're doing right now. And then also as well, one of the things I will also leave with is sort of a cheat sheet. So as you read this stuff in the literature, some of the key questions you probably want to be thinking about asking of any particular study to really sort of burrow down as to the real value of what that study might be providing. First of all, most people are kind of like behavioral science. Sounds great, have no idea what that is. So let me just define that for you, and specifically to broadly behavioral science and behavioral medicine, which is sort of really what I do. So I have there is some people in the audience, which is great, but just by a quick show of hands here, who here would consider themselves a behavioral scientist? And for those online that can't see, absolutely nobody raised their hand whatsoever. And I don't know if anybody online raised their hand because they could do so at the same time. One person, excellent, excellent. It's normally a very low number of people. There we go. Yeah. Behavioral science is universal, so that is a completely good and appropriate answer. Okay, so actually, most people don't recognize themselves as a behavioral scientist, but most people, a lot of people do a lot of behavioral science, okay? And most people don't actually know what behavioral science is, and I'm not going to belabor asking you what it is, because this is the definition I'm going to give you. So behavioral science, intersectoral approach to study of normal human behavior and decision making. And I contrast that with, for example, clinical psychology, which is all about abnormal behavior, where things go wrong. Behavioral science is really interested in the things that we do on a very regular basis. And a key element of that is not necessarily just the doing, but it's the decisional process that sits behind it as well. Though behavioral science started out of psychology, it's really expanded to be a very multidisciplinary, intersectoral field that encompasses a lot of different methodologies. Um, and ultimately, the goal of this is to really understand those behaviors and then positively change them. Behavioral medicine is just the application of behavioral science to health. That's simply it. Okay, so that's why I work in behavioral medicine, because virtually everything I do is really focused around trying to improve health. Now, what are some examples? Most of you would be very, very quick to point out things like physical activity, diet, and smoking. These are the things that most often people talk about and think about in terms of behavioral science. But there's a whole bunch of healthcare behaviors, which are also behavioral science as well. Medication adherence, attending appointments, reporting symptoms. That's all behavioral science. In this new telehealth world, there are digital behaviors, the action of logging in, completing questionnaires, engaging with materials. It's all behavioral science. And then in probably more close to what a lot of people within the broader ACT community are interested in is trial behaviors, right? So recruiting diverse populations, consistent intervention delivery, and then retaining people. Okay, these are all aspects that behavioral science can inform and has informed over time. So I'm not going to talk about all of this, but just to identify, and I always feel a little bit like a megalomaniac when I talk about it, because behavioral science touches upon so many different aspects. The things we do are prevalent everywhere. Okay, so now I'm going to get to now explain what I do and what all of this is. I'm going to get to the talk, and you're probably scratching your head saying, why am I showing a drug as a behavioral scientist? But there's a good reason behind this. So we have drug X. There's a prize for anybody that can work out what drug X is before the end of the talk. How do we get to drug X being on to the market? How does it get to the market, right? So this is nothing unusual to most people to think about, right? So we go from 5 to 10,000 compounds. We go through a series of rigorous steps that then ultimately get to the winning drug that then makes it to into practice. Most people appreciate that takes somewhere in the region of 10 to 15 years, give or take. And it costs a hell of a lot of money. Most recent estimate is about $1.6 billion to do that entire process. It's long and expensive. Also, as well, if you actually look at any particular molecule that you start with on the left-hand side, the probability that it makes it to the very end is about 0.07%. So that means we've got about a 99.93% chance of failure for whatever we develop at the beginning. Okay? That's one drug. Think how complex a behavioral intervention is relative to that one drug. And then think about the process that we go through to try and jump things into practice. Now, I'm going to come back to that at the very end, but I just want to plant that seed, right? Why do we need to do better with our behavioral interventions? Okay, so I promised some failures, and there have been many. There's just a few selected here. I could fill pages and pages of this. I'm going to pick on one particularly. Anybody who knows me knows that I love to pick on look ahead. This is a trial that it's a little bit old now, that looked at the impact of sort of behavioral weight loss intervention on major adverse cardiovascular events in patients with type 2 diabetes. Okay, and as you can see, it wasn't published in a too shabby journal, New England Journal of Medicine. So pretty impressive. What is look ahead? For those that don't know, it's about 5,000 people randomized to two groups. First group, a super intense intervention targeting reduced calorie intake, increased physical activity. They had weekly counseling for 6 months, and then a reduced schedule beyond that, but still actually intervening for 10 years. The comparison group was diabetes education. That was 3 times a year for 4 years, and then reduced after, still going for the entire 10 years of follow-up. And this was their their outcomes. And I won't get into debating the list of MACE in there because it's a bit of an odd list. As many of you will probably look at and go, cost $100 million US. Okay. So it is the largest, most expensive behavior change intervention trial that has ever been done. Okay. $100 million, 10-year follow-up. So you've got to imagine that this must have been pretty spectacular. No. But hey, but look, it gets a little bit separated. We blow it up, is it? No. Okay. Absolutely nothing going on there whatsoever. Now, if I showed you, and that's just to prove it, that's the hazard ratio. There's nothing there. No difference between comparison and intervention. Now, what do you think clinicians take away from that? Okay. Sorry? Go back to McDonald's. Yeah. I mean, this came out just as I was involved in Diabetes Canada's set of guidelines that we did after this. And it was really interesting, the conversations, because there were some believers in there, but a lot of people kind of were like, a lot of physicians were kind of like, well, look ahead, this mega massive trial. And what does it show? Nothing. What's the value of doing behavior change in my patients? Totally legitimate question. So the clinicians aren't particularly excited by this. And then clearly the idea that behavior change gets implemented into any long-term strategy diminishes quite significantly. So when we think of a null trial, what are the possible things that really explain that? So the first is clearly a failure of the hypothesis. And this is what most people take away from it, right? That there is really, no effect of behavior-focused weight loss interventions in this population if you want to impact major adverse cardiovascular events. But it's also possible that this is a failure of the intervention or a failure of the study design. And what I'm going to do is just use this as an example of some of the thinking that maybe we could have done a little bit differently or could be done differently that might mitigate that. So firstly, let's look at the behavioral targets that they had. And the first thing I'll declare up front is weight is not a behavioral target. So I'm talking about this as a very much distal proxy of both their diet, combination of diet and physical activity. And even then, there's a whole bunch of things that influence weight. But this is what they detail as their two behavioral targets. So did they achieve a 7% reduction in weight relative to the comparison group for the intervention arm? If you actually look at the intervention arm, we see what we classically see, massive weight loss very early, sort of rising up a little bit, and then they get this very stable kind of level. That level is actually about 7%. So you sit there and you're like, ooh, that's pretty good. I mean, that's quite impressive unto itself. Problem is their comparison group, which, if you go back, that's, a lot of diabetes education and a lot of constant follow-up and so on, which is probably a little atypical. I haven't met a clinical situation yet where I've seen that good a quality of standard of care or usual care in diabetes. It does a phenomenal job. So what happens is at the end of the day, the absolute level of weight loss relative to the comparison group is not 7%. It's 4%. So they're achieving about half of the expected weight loss. So that flags that maybe there's an issue, a design issue here in terms of what their comparison group is. Maybe there's a design issue in terms of their intervention isn't potent enough. Okay, so that's sort of a proxy of a number of things. Let's look at physical activity. Their target was 175 minutes of MVPA. This was because when this study started, the mantra of 150 minutes was not ingrained in public policy. So that's why, because it's an odd number. So what did they find? They didn't report it. So at 10 years, in the final paper, they have the weight stuff, but they don't have the physical activity stuff, even though this is a key target for them. But, when you spend $100 million on a study, you better publish a damn sight of a lot of papers. And thankfully, if you dig into the archives, they've published some stuff on this. So this is Jessica Unik, who published a study looking at the physical activity piece up to 4 years. And in the black, what you see is the intervention group, and in the gray is the comparison group, right? And straight off the bat, what you can see is by year 4, only less than 20% of the people are achieving the physical activity target. And it's significantly down from year 1. So you can just imagine what that might look like at 10 years, okay? Nowhere close to achieving even 50% of the people doing what they're supposed to be doing. More concerningly, when you look at the baseline levels, you know, there's about 16% of the total population are already doing that level of physical activity. So let's just think about that in context, right? You've got a group of people who are doing the level of physical activity that you're trying to intervene on. Okay, so that's the same as me saying, I'm going to give smoking cessation to people that don't smoke. Let's see how that does. There's no behavior to change here. Okay? You're going to give antihypertensive patients that are incredibly normotensive. Nobody would think that was a good idea either. Yet here, you're trying to change people's physical activity when they're already doing the level that you want them to get at. So this is a whole study design issue that's hugely problematic. Now, if we look at the intervention, where did the intervention come from? Okay, and I can tell you this is about as much detail as you're going to get. They have a whole protocol paper. The whole protocol paper gives you very little more than just this. Effectively, this is a throw everything in the kitchen sink into the mix and see if it works. So it's modeled on the diabetes prevention program plus, 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 plus. I'm going to talk about DPP in a second. Multiple elements drawn from all over the place with the belief that this might actually work, but was never formally tested. $100 million of public money. I mean, if it's me, I'm kind of like, just give me 1%. Let me just do some like early phase testing. Let me just see if this thing actually sticks. Anything, you know, cool million would go just beautifully. But this is not atypical. And this is where we find ourselves with a lot of the work that's done in the field. Now, I'm going to talk about DPP very briefly because this is another key kind of failure come success, how to draw failure from success. Once again, DPP was published in New England Journal of Medicine. Effectively, the group that developed Look Ahead were the core group that did DPP. So this was sort of the run-on study from DPP. And for anyone that knows the DPP, it's lauded as the greatest success in behavioral science, certainly in behavioral medicine, okay? Because not only did the behavior change intervention beat the comparison, the control intervention, it also beat the drug. And this is people who are at risk of developing type 2 diabetes were recruited, and it's transition to type 2 diabetes is the outcome. So similar, but not the same population as Look Ahead. Okay. The level of intervention was as complex. And so what we see is this was published in 2002. You plot out the number of studies that have actually done any work on DPP, and it's in total about 1,600 studies that have then subsequently done work on DPP. Virtually all of that has been about how the hell do we do this in practice? Because I mean, could you do weekly interventions for 6 months following another 3 to 4 times per year for multiple years after that? Clinically, nobody in their right mind is going to be able to deliver that. And it's multi-level, right? So there's multiple interventionists working on that. So this leaves us with 2 fundamental problems. Number one is our intervention generally poorly developed? And then when we do have fantastic successes, they're almost impossible to implement because they're not built for implementation. So that's the failures. And what do we do to make this a better situation? Okay, so a lot of people have been working on this for a very long time. And at the core of it is various different development models. I'm going to present one because it's the one I like, but this is not the only one. There's also the MRC complex interventions model as well. And there's a few others out there. But the MRC and this orbit one are probably the 2 most highly used and probably the 2 most famous. And what I'm going to do is very, very briefly just walk through some of these steps and talk about, well, what do we do differently? The first thing I'll highlight, obviously, is this sort of maps onto, to a large degree, sort of the drug development model. And that's done purposefully because this is supposed to be for a behavioral medicine context. Okay. Before I do that, at the very core of all of this, by the way, and this is something that people don't do but need to do more often, is actually develop your intervention cascade. So how the hell's my intervention supposed to work? Something we don't actually talk about that much. Here's a question for you, just quickly. I'm going to do this by show of hands. Is exercise a behavioral intervention? Raise your hand, and you do this online as well. We're counting, so don't be shy. Raise your hand if you think exercise is a behavioral intervention. Okay, and absolutely everybody in the room raised their hand. Online, 4 online. Oh, okay, yeah. So a little more conservative online. Oh, back to 4. Okay, exercise is not a behavioral intervention. And I have lots of quizzical faces here in the room. For those that are online, can't see. So what the hell is, if it's not, what is? Okay, so I'm going to talk about what is a behavior change intervention. This is really important. This is at the core of where we need to start reconceptualizing. So this is a model that I'm going to talk about very briefly. At the bottom here is the intervention. The intervention is a function of content and delivery, the things that we give people and how we give it to them. And these things ultimately work through a mechanism of action that change a behavior, and then obviously people's engagement with it in their particular context has a huge influence on that path. What you do, okay, is actually a whole series of behavior change techniques. And if there's one thing that I want anybody to take away from this talk right here, right now, is a behavioral intervention, behavior change intervention is just a package of behavior change techniques. I'm going to explain what they are, but that's what it is. And then the delivery part is just how you're going to give those to people. In person, 2 times a week, 3 times a week, online, various formats, etc. The mode in which you get it out to people. So what is a BCT? So very kindly, there's a group in UCL led by Susan Mickey that's done a ton of work on this. The first version was the behavior change techniques taxonomy that's now been updated to the behavior change techniques ontology. And they have accumulated all of the evidence that's out there and then tried to distill all of this. It's been a huge international effort. I'll tell you now, it breaks down to the very micro level. There's about 280 of these, about 280 things. This is the higher sort of level ontology that gives you the broad categories. Okay, so what are we talking about? Let me give you a good example. Goal setting, right? I think anybody that's ever done a behavior change intervention, goal setting is a fundamental part of that. Identifying things like SMART goals, right? This is actually the intervention that you are delivering. If I was actually delivering an exercise intervention, technically it'd be me grabbing hold of people's legs and pushing them around the bike. That's me giving them the exercise intervention, if you actually think about it. So this is the package of things that you've got to start thinking about. Well, what do I actually need to deliver? What are the pieces that are really important for me to be able to get that person to change the behavior? And exercise is a behavior. It is an outcome. Okay? It's the thing we want people to do. It is not the intervention. This is the how we get them to do the intervention. Okay? So I'm going to take all that information, I'm going to plug it into this. Okay? So this behavioral intervention cascade. What does this look like? And I'm going to use use look ahead as an example. My behavioral treatment. So these are just 2 very classic things that we do. Self-monitoring, getting people to record the things that they do, and behavioral rehearsal, showing people things and then asking them to repeat that in front of us. Okay, so that's our actual intervention. What's the behavior we're trying to directly influence with that? Well, if it's self-monitoring and it's for food, we want them to record the calorie intakes, the food intake and the calories. Okay. If it's For exercise, we want them to do some pre-planned exercise. Get them to come into the lab, we show them what they should be doing, we get them to practice it in front of us, and then we hope they go off and do that outside of the lab. But we need to know how much we need to change the behavior to actually have some important clinical impacts. So our behavioral risk factors, here it might be reducing calories by 500 a day, and it might be ultimately trying to get people to 150 MVPA, moderate vigorous physical activity, for example. Those then subsequently change some kind of clinical pathway that then lead to the ultimate clinical outcome. And then also acknowledging that there are these other ways, other mechanisms that changing these particular behaviors might actually lead that might not be directly through the specific biomedical risk factor. But really highlighting here, very important, at this end, okay, this is the intervention. Exercise, not the intervention. That's the intervention. Okay. Now, quickly, I'm going to quickly run through this. At the very core of this model is this significant clinical question and implementation science. That's where you start from. How do most people create their clinically significant questions in the behavioral sciences? They use Islagiat principle. Anybody here know what the Islagiat principle is? Okay. It seemed like a good idea at the time. And trust me, some things are never a good idea at a time. I cannot tell you how many grants I have reviewed where people have gone, you know, exercise is fantastic for blah, 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 blah. So we're just going to do exercise in this group over here. Unbelievably. Or, you know, flavors of that kind. Okay. And that's just not good science. There's no actual reason why necessarily you just transplant one thing from one side and put it in another. The parallel would be me going, you know, ibuprofen's got sort of anti-inflammatory properties, cancers of inflammatory disease. Hey, let me just do a phase 3 randomized controlled trial on ibuprofen for cancer. Same logic. This behavioral intervention works in this place over here, so therefore it must obviously work over here. Okay? That's not a good idea. So what should a good clinically significant question be? So a question for which a question or problem for which a behavioral treatment could provide a solution. So there's no current treatment. Current treatments are potent, not durable. Current treatment is effective. Adherence is poor. Current treatment produces too many side effects. Have a really clear understanding of the clinical issue that needs to be solved for which a behavior change intervention is actually going to make that better. And oftentimes when I ask people this question, they have a very hard time really articulating that. They can identify there's a clinical problem. They can identify what their interesting intervention is, but what aspect of the clinical problem are they really solving? Implementation science. This is something, you know, I think DPP was a perfect example of this. We don't think about this ahead of time. We just think about, oh, how do we optimally change the behavior? I don't care if it gets uptaken or not uptaken. It's just, can we get it done? And, you know, you might have an experimental mindset where you're just interested in understanding how a behavior impacts something. That's fine. That's not gearing your intervention for clinical utility. But you always need to start with the end in mind. This requires full engagement of all key and interested and affected parties. And I know that, you know, here in Canada, we've been much better at doing this than many countries in the world, at really engaging this. Our focus has predominantly been on patients and community members. But I think, you know, what we do within our research is actually have a very strong focus on the healthcare practitioners and the administrators. You know, I could build something that the patients love and will engage with, but if the healthcare practitioners can't deliver it, won't refer to it, don't believe in it, and the administrators won't pay for it, who cares? It's not implementable. You need to have all levels of this at the beginning as you start to develop your intervention. Just a very brief sidebar, because I'd like to big up all the behavioral scientists I can as possible. So implementation science wasn't something that was developed by behavioral science, but probably in the last 15 years, the greatest advances in in implementation science has come from behavioral science. And fundamentally because implementation is about getting people to do things differently, whether that be managers, service commissioners, providers, administrative staff, et cetera, et cetera. They've got to change their decisional processes and they have to change the things that they do. Practice only changes when people do things differently. But hey, yeah, change. Okay. All right. So once we've gone to there, we go basic science. And the good news is we have a ton of this. You know, we've got a whole plethora of things. We've got, you know, pretty good behavioral, good animal models that understand behavior. We've got great bunch of longitudinal data, imaging studies, epi data, qualitative work, et cetera, et cetera. A really good deep understanding of all the aspects that sit around the particular clinical problem and the behavior that you're thinking about trying to change is fundamental. This then sends us into this define and refine piece. For the define and refine, really what you then need to start doing for the define is saying, okay, so I understand my problem. How do I start building out that behavioral cascade, right? What pieces do I need in my intervention? What might be the mechanisms of action that these are actually going to work through? What are the elements that I get a good sense are going to work? Define it, map it, lay it all out. And then the refine phase is, well, there's some bits I don't understand. So I need to do some like preliminary testing. I need to do a little bit of, do I need 2 doses, you know, 2 sessions of this? Do I need 4 sessions of this? Do I have goal setting, then self-monitoring? Do I do self-monitoring, then goal setting, et cetera, et cetera? There is work that needs to be done. Most of what you're trying to do here is really get a sense of this fledgling intervention that I have. Can I start changing the behavior to the point where the behavior is clinically important? Don't really care about a great deal of statistical difference. I don't really need to have a comparison group. Who cares if I randomize to a comparison group if I can't even get my intervention to do what it's supposed to do? Okay, makes no sense whatsoever. So this very early phase stuff, small, short, quick fire studies, and there's some very elegant designs on the refined side that you can use, that you can test a whole bunch of things in parallel and in series. And then in series. Okay, so once you get past that, you think you've got something, you're into then proof of concept. Now, there is a litany of literature in our field that talks about pilot studies. And I'm going to talk very specifically about pilot studies. In fact, what they are is a whole series of proof of concept studies. We do 1,000,001 proof of concept studies. Our first shot at understanding, does this thing work or not? Okay. Proof of concept, though, really is not about ultimately the end clinical goal. It's still about that. Do I have a final package that can actually change the behavior consistently in the population I'm interested in with the same, with enough of an effect that actually matters? And then once you've sort of said, yeah, I've got this, it's good, then we're into feasibility and pilot studies. I just said that part. If you do have a comparison group, you need to be able to test this thing. Okay. So, do I have minimal change in my behavioral risk factor? You know, clearly look ahead. They never actually even thought about what the impact of the comparison group was going to be. They just assumed it would be null. They wasn't going to do anything, right? What about dropouts and crossovers? Is the comparison group credible and acceptable? These are all things that need to be tested. You can do this during the proof of concept process. You don't need to randomize people to this necessarily. You just have people do the intervention piece or the comparison piece, right? Very important as well. This is something we don't do very much either, is actually preparing a treatment manual and the procedure for fidelity monitoring. Once again, we've got a whole bunch of great studies where in this particular lab, they have the inherent knowledge, they deliver the intervention, and then nobody else can do it because they didn't protocolize it. We have no idea what the key markers of what the interventionist needs to do to make this happen. Okay, no way of monitoring if this goes to another lab, whether it's going to be successful or not. Behavioral outcomes are the focus here, not the clinical outcomes. Statistical significance is not important. You want to start creating go, no go criteria. What proportion of my population do I need to get above X level of behavior change before I can say that this is a good enough intervention to move forward? Because if I do pre-post testing, or even I do some comparison testing and I get my people to exercise for another 5 minutes a week, that might be statistically significant, but who cares? In the whole scheme of things, is that a particularly potent intervention? No. And it's really centered around this idea of understanding what the minimally clinically important difference is in that behavior that you're trying to change. And this is where a lot of people trip up, because we don't have a great deal of information about what that is. And there's quite a lot of work that people need to do to figure that out. Good news is there's a whole bunch of basic science pieces in there, epidemiological work, for example, that can actually be leveraged to try and figure out some of this stuff. Feasibility studies. Feasibility studies are tied to a final trial. A feasibility study is about can a trial be done? Should it be done? And if so, how? It is not there to measure efficacy. It is purely there to understand things like recruitment, procedures, et cetera. And I get my people through this. Pilot studies are just a subclass of feasibility studies, where explicitly you are testing randomization, the feasibility of randomization. By the way, this is not a behavioral science definition. This is a generic universal definition of feasibility in pilot studies. It's not unique to us. This is generic. And I know, having been here before with some conversations, that we haven't always agreed on what that might look like, but this is sort of generally the accepted version of this. Purpose is really about that future trial. They're totally tied to the future trial. They're not standalone studies. They ask questions about process, resources, management, treatments, not the effects of the treatment, but the delivery of the treatment. Okay. And I said, test aspects of randomization. You can look at willingness to participate, crossover, adherence. Ultimately, the pilot study gives you a window into how you should conduct your full study and nothing else. Okay. I won't go through that. The main outcomes is really 4. Continue without modifications, continue with modifications, without modifications, but monitor closely, continue but modify, and then stop. Don't move forward. And I think one of the key things that we don't tolerate well is giving up on something and stopping. We're so desperate for one of the top 3 to be true, and not just within feasibility and pilot. This is proof of concept. This is define and refine. But let me remind you of that figure I showed you at the very beginning. Any particular drug that any particular company develops or any individual develops, right? 99.93% chance that it will not be successful. A lot of what we do will not be successful. And I think we have to start living with the fact that that is true and stop trying to shoehorn it and believe that it's just, if we keep pushing at it, it'll work, it'll get better. Some things we should just stop. And then finally, we move on to efficacy trials and effectiveness trials, which I won't talk about because everybody knows here about phase 3 RCT kind of model and then moving that into a more pragmatic kind of structure. Okay, so that's sort of a very quick run through. And really, if you want to develop behavioral interventions and properly test them, these are the steps you really need to do. So when evaluating a paper, have that model in mind. You can think about, was the intervention properly developed? What do they tell us about the intervention of it? Is it being delivered to the people that should be getting it? Am I giving smoking cessation to non-smokers? Is the behavioral target of the intervention being measured? Well, you'd be amazed at the number of studies that are targeting a particular behavior, don't actually report it in their final papers. Just skip to the clinical measure. Comparison group appropriate. What was the fidelity of the interventionist? Are there any measures whatsoever? No, that's really low. So we have no idea how well this thing was actually delivered, even if we know what it is. Okay. So I showed you this slide. Now I'm going to take this model and let's reconceptualize this into what we probably should be doing in terms of developing our behavior change interventions. Okay. So rather than think about, 5 to 10,000 compounds, we're probably thinking here about, BCTs and delivery modes. There's an infinite number of potential combinations of that. We need to be testing a whole variety of those in micro settings. That's our 5 to 10,000 things that we really need to be thinking about. That probably leads us to a smaller number of packages. How might I be able to put these pieces together? That might vary by circumstance, by population as well. So how much variability do we have there? We test that, the refine, define phase. Then we have our sort of phase 2, phase 3, etc., where we're taking phase 1, phase 2, sorry, where we're taking our 5 packages. We've done all our define, refine, and we're saying, you know what, we've got 5 pretty good contenders of what our intervention should look like. Let's give them some legs and really try and test them, so that ultimately, at some point in time, we'll have a really great implementable intervention that will have real clinical impact. We certainly need to stop skipping to phase 2 and phase 3 using an Islagiat principle of why we should do that science. Time and success are always things that we have to get more comfortable with. And the one thing I will say is that we need a lot of team science as well. I work along this entire continuum, but not within any one project. I got projects that I'm doing at the early phase. I got projects that I'm doing at the later phases. And for the later phases, I'm leaning on the work of other people. For the early phases, I'm trying to feed into what other people will do in the future. I doubt I will ever see the work that we're doing at the early phases. I won't be around long enough to see it actually mature into something concrete at the end. That's the timeline. So hopefully I achieve some of these objectives. But most importantly, things do not change, we change. So this is a bit of a challenge to everybody here, that if you are thinking of doing things that target changing behaviors across any of that spectrum, to do things a little bit better than have been done so far. That's the amazing team that sit behind this and a whole bunch of really great collaborators and funders. And thank you.
Thank you so much, Simon, for the amazing presentation. So I have used this phased approach in a couple of projects, the orbit model, and I think it's great. We really find out a lot of good things about the intervention before going into the larger trial. What I find is it's hard to get funding for the initial phases. CIHR is not really into it. In my experience, I don't know if I did not frame it well, but I tried to use the framework and explain the importance of the first steps. But in your experience, have you been successful in getting funding, consider like good funding for the first steps? And do you have any suggestions for us?
Yeah, no, that's a great question. It's the one that most people normally flag. It's like, it's impossible to get this stuff funded. It is difficult because we have a relatively uneducated peer review situation. And not just here. It's also true. I have this conversation with a lot of people at NIH as well. NIH developed the orbit model, and yet, there's still so many reviewers in their system that are completely ignorant of it. So when people bring stuff, it can be difficult. So it's not straightforward. I'll say that. What I have seen, so yes, I have had funding for this stuff, and I've been on peer review committee where I've seen some amazingly well-written grants. The key thing is being super clear about anchoring the significant clinical question at the heart of all of it. And when you anchor it there, and then you explain about depending where you are on the phase phases in the list, right? So you anchor the question, you give them the model, you say, this is what we know, and this is what we don't know, what we need to know. And then you give them a roadmap that once we've sort of worked out what this is, here's where we're going with it. And if you actually structure it in that way, I've seen, as I say, I've seen some people write some really elegant grants like that. Most of the time, that stuff gets good traction. And that's where I've seen it been really successful. Because what you're doing is you're not saying, everything's in context, and you're making a really clear argument as to why we need to be doing this part of it at this point in time. And maybe, normally what happens is you put 2 or 3 pieces together that then have a natural flow to them. You identify the clear outputs that are going to come from them. So it's like, oh yeah, okay, we see how the science is going to move from this. And that's been the way to be successful. I think with all, at this day and age, it feels like most grants are a bit of a crapshoot anyway. Even the really, really great ones don't always make it. But that would be my suggestion.
Going to make one comment. So thank you. That's very helpful. I think what is frustrating is the misinformation of the reviewers, but also the fact that the model says that you can go back and modify, especially the phase, the define and redesign and design, go back. So this is an issue for them. Well, if it doesn't work, we're going to give money and then we'll go back and do it again in a different way. So I think that's the challenge for reviewers to understand.
For sure. And I think the key is being, you may be overreaching as well, right? So if you've got this expectation that you're going to be able to sort of, within one particular grant, do multiple phases, that's probably over-optimistic in reality. You could probably get a certain point in time, there's a logical piece where you're going to gain enough information to be able to say, I've learned enough to be able to start thinking about what that next step is. But at this moment where I'm starting from, I don't have enough information to say what that would look like, and therefore how much is it going to cost, how long is it going to take, what resources am I going to need, et cetera, et cetera. So, there is this sort of, you can only go so fast in any particular grant. And I think that's a key trick in writing some of this.
Thank you, Simon. Excellent presentation. My question is really about the implementation piece. So when you're kind of, I guess you've established the proof of concept through your prior studies, and you want to go to the pilot or the feasibility, or maybe you're doing an internal pilot, and you want to really hit home the implementation piece about it. And I've read about these hybrid effectiveness implementation trials. What's your sense of that? And just here at our institution, we don't have a lot of expertise in implementation science.
Yeah.
What's your recommendation and kind of, hitting that home quickly in the beginning?
Yeah. Okay. So that's a great question. I'm going to show you a couple of slides because I had an anticipation. So I think the issue is really about the fact that you start at the very beginning with this. Right. So I'm just gonna, there we go. So this is our real early phase stuff. It's the interchange program. I won't get into too much of the details of it, but it's adjunct behavioral interventions for bariatric surgery. And this is really, that's the clinical question. It's got a bit wonky. This is all the work that we've been doing. So the first 3 are in sort of the basic science size, and then 4 and 5 are in the phase 1 stuff, the define and refine piece. So we've done a lot of work here. The patient survey, the eDelphi, and actually 2 to 5 has been really fundamental in really thinking about how do we structure the interventions. Metabolic bariatric surgery is fantastic. You use a bunch of weight, except it doesn't work very well for everybody. It's only about 50% of the people that get real benefit, and there's a huge amount of weight regain afterwards, and people are generally unhappy throughout this whole process. There's a huge amount of problems. As clinically successful it is, so we need this stuff. This is the critical piece. When we first started this project, this was the team that we pulled together. So we've got our researchers, but we've got patients, we've got healthcare administrators, we've got surgeons, we've got nurses, we've got students. We're sitting there developing an intervention that is built for implementation straight away. Number 1. Number 2 is we're already starting to build our set of champions, the people that are going to be able to talk to their peers and start saying, hey, this is a really well-developed intervention. It meets some of our needs, majority of our needs, hopefully. And that this is how it's been developed. So I think you have to start with this firstly, because if you do that, then you automatically start to develop the intervention that you can almost, I'm not a huge fan, I'll be honest, of sort of a standard phase 3 RCTs in our field. I don't think they tell us very much. And if so, that's one thing. And the other thing is, if you think about, PROCEES as a way of evaluating any particular trial, everything lives on a continuum of, totally efficacy all the way through to totally effectiveness, right? No study is at one end or the other. So then the question is what study do I start to build that actually I can do, which is going to give me enough quality data to show real world impact? And you're always trading certain pieces of that. But if your intervention's already built for implementation, a whole bunch of your barriers are already gone, right? So I know I didn't answer that directly because I don't think it's a direct question. What I would say is implementation is at the beginning, it weaves its way all the way through. And then when you come to your final design, depending on the nature of the intervention, you're already way ahead of the game. And then you get to the really key questions that you need to answer and then develop the study to answer those questions.
Thank you. Anyone else have questions here? You're already on Zoom? Great. Thank you so much. That was amazing. And we learned a lot. So thank you.
Thank you.